you must be a chiropractor.
Yes, I am.
All right. Would you tell us a little bit about yourself and what led to this series of articles in Healthcare Business Monthly?
Uh, you don't really know where to start with something like this, but I guess it started. Um, I had purchased a practice just in 2007, which is now, in hindsight, now it's just the ultimate in bad timing. But during that time, I had become certified in compliance. And then 2008 hit, and I wasn't able to maintain the practice, so I gave it back to the person I bought it from. And um, I was sitting there trying to decide, well, now what do I do now? And the OIG very conveniently issued a report on chiropractic that just after I read through it, it just angered me because they had painted chiropractors, as either half the profession is either fraudulent or too stupid to know how to document. And I thought, okay, now there's got to be something wrong here because I know chiropractors are not stupid and I know they're not fraudulent. So it has to be an understanding of the regulations. And that started me working on a process of learning the regulations and getting them out to the profession and translating them into actions doctors could take to improve their documentation and better deal with Medicare and with insurance and and as I worked through this, the more I worked through this, the more I realized it's not just the chiropractors. The insurance people are denying claims that are fine. They're saying that visits are not medically necessary, that are just fine. So there has to be a lack of understanding on the part of the reviewers too. And the more I talked to them, the more I realized that was the case. Um, Whenever a reviewer looks at a visit from a medical doctor, they're looking at an E&M visit, regardless. That's not the case with a chiropractor. There are a few E&M visits in there, but most of the time they're looking at treatment visits, and that looking at one of those and determining the medical necessity of care would be like um, taking all the notes that are generated after the patient takes one pill in a course of amoxicillin and determines if that course of amoxicillin is medically necessary. You can't really do that. So I've been working on ways to communicate this, to explain it so that um, reviewers can understand. These articles are a result of that. Earlier this year, I did a 1 hour webinar on chiropractic and understanding it. Um, February 27th, we have a workshop, 4 hour workshop scheduled on reviewing chiropractic claims through the AAPC. I'm real excited about that, and I'm just now finishing a book on auditing chiropractic claims. So I'm working on the tools necessary for everyone to understand what's going on and to work better with it.
Awesome. I love it. Claire, John, do either of you have experience coding for chiropractic care?
I do not.
Okay.
I
I
do.
worked for a chiropractor when I was 17.
Okay. All right. So you know that road a little bit. John, tell us about your experience with that. And have you experienced any of the challenges that Dr. Short speaks of?
Yeah. When you're doing chiropractic, and this is one of my earlier jobs in my coding career, is I was an office manager for a small chiropractic physical therapy office. And it was it was maybe two doctors, one physical therapist and one chiropractor. So I was doing management stuff as well as all the coding and billing and A&R. So when it comes to that, a lot of the notes are like handwritten drawings. Like I was brought on when it was in the EMR transition. Everything was going from paper to electronic. So a lot of notes for chiropractic are images of the human body, of the lumbar, thoracic, cervical spine, with like handwritten notes, like where the issue is, where there's most subluxation, and not so much any kind of like like audible documentation like you would see in an E&M note. It's pretty much like it's kind of drawn out like it's a physical therapy note. So when they're treated, it's not like they would do a full dictation. Oh, there's actual pain in the lumbars and there's difficulty. They would draw it out and then would go on with the therapy because that's where a lot of time was spent. They're not doing it to evaluate, they're doing it to treat. And it's mainly treatment with maybe 1% evaluation time. Would you say that's about accurate or smart? Like a short?
Yeah, here's how I've laid it out to explain it to non-chiropractors. Chiropractic care is episodic. It starts with an E&M visit, and that E&M visit is a standard visit. And from the time when you started, when you worked in the chiropractor's office to now, things have improved quite a lot. There have been, I'm not the only one that's been teaching the profession about how to properly document. And now the way we do it is we start with an E&M visit, and it's like a standard MD, chiropractor, osteopath, doesn't matter. E&M visit is the same thing. We get to know the patient. We do the exams. We do the subjective, the objective. We write the assessment. We make the plan. Then we have 30 days of treatment visits. And that's where we execute the plan. You cannot take a single treatment visit and determine medical necessity from that. But then at the end of that 30 days, you do another E&M visit. You determine how the patient's progressed and if they need more care. And there are tools that we use. There are thresholds on those tools that say, yes, the patient has a significant problem. Yes, they've made significant improvement. Yes, they need more care. No, they don't. And to determine medical necessity, you take the E&M visit before, all the treatment visits, the E&M visit after. You look at that as a whole, and from that you determine what's the care medically necessary. And it's very clear once you understand it.